Most medical students memorize anatomy to pass an exam, but great doctors memorize it to save lives. A fall on an outstretched hand does not just injure the wrist or shoulder. The force travels along the upper limb to the clavicle, the only bony link between the arm and the axial skeleton. The sternum forms the anterior midline of the thoracic cage and is divided into the manubrium, body, and xiphoid process. The sternal angle, also called the angle of Louis, is the ridge at the junction of the manubrium and the body. It lies at the level of the T4 to T5 intervertebral disc. This plane marks the articulation of the second costal cartilage, which is why rib counting always begins here. At this same level, the trachea divides into the right and left main bronchi. The aortic arch begins and ends, and the azygos vein curves forward to enter the superior vena cava. The clavicle is a long bone with a double curvature. The medial 2/3 bulge anteriorly, the lateral 1/3 curves posteriorly. It functions as a strut that holds the shoulder away from the chest wall, allowing full mobility of the upper limb. The junction of these two curves is the narrowest region and the most common fracture site. After fracture, the sternocleidomastoid muscle elevates the medial fragment, while the weight of the arm and the pull of pectoralis major displace the lateral fragment downward and medially. At the superior border of the manubrium lies the jugular notch, projecting to the level of T2. It provides a fixed midline reference for the superior mediastinum. Inferiorly, the xiphoid process marks the end of the sternum at approximately T9. In younger individuals, it remains cartilaginous, becoming ossified later in life, but it is always fragile. The sternoclavicular joint is a saddle-type synovial joint, strengthened by anterior and posterior sternoclavicular ligaments and an intra-articular disc. It is the only true joint connecting the upper limb to the axial skeleton. Posterior dislocation is rare but dangerous because immediately behind it lie the trachea, esophagus, brachiocephalic veins, and the great arterial trunks. Even minimal posterior displacement can threaten breathing, swallowing, or venous return. Clinical anatomy of the chest and shoulder is the study of fixed landmarks and predictable forces. When structure is understood, injury patterns are no longer random. They are expected.